We're going to main meeting portion now. Just going to check the time to make sure I know where we are in time wise. 124. Okay, we're not too bad. Actually, 124 is not too bad. All right. I'm just going to do a little bit of quick housekeeping since we are moving into the main portion of our meeting. First and probably most importantly, if you're here in person and you want to know where the restrooms are, they are just out these doors to the left around the corner. And looks like we already have a taker for that. So we are doing hybrid. This hybrid setup's working really well so far, knock wood. I hope I didn't just curse us by saying that out loud, but everyone who's sitting around the table, these microphones right here in front of you actually are automatic. You don't have to press any kind of button. It will pick up your voice when you start talking, which is great. And it means we have to really minimize any side conversations so we don't disrupt people's ability to listen on Zoom. And also just even with the mics, it's good to speak really clearly and loudly when you're speaking in the room so that our folks on Zoom can participate. I'm going to do my very best to keep facing you and checking the Zoom board here to see what our CRIS members want to contribute to the conversation, but I have folks helping me catch that if I miss it. So please bear with me if I take a minute to see if you wanted to make a comment today. Just a few quick things in terms of our Zoom etiquette today. It's going to be a little bit different than usual in our in the room etiquette. If you are sitting around the table today participating as a CRIS member, you have a table tent. If you could, when you want to offer a comment or question, just turn that table tent on its side. That'll let me know that you want to speak, and I'll try to track the order in which I see it. Folks on Zoom, for CRIS committee members, it's our usual drill on Zoom. Please, if you can, keep your video cameras on and your mute buttons on, so have your mic muted and your video cameras on. That'll help me be able to see who's on that's participating on Zoom and also avoid any background noise. You can use the raise your hand function to let me know if you want to offer a verbal comment or ask a question. If you want to offer anything by chat, please actually send it to Michael Anderson Nathy today. He is tracking those chats for me and will interrupt me periodically so I can add the chats to the discussion. And then finally, as I always let you know, if you want to be able to see more people, you can click on that speaker view and change to gallery view. Want to advance the slide, please? Can you advance the slide, please? Perfect, thank you. And then members of the public, if you could keep your mics on mute and your video cameras off, that would be great. I think we just have a couple of members of the public in the room physically today, so nothing for you other than during the main discussion, I will just be calling on CRIS members. But if you would like to make a public comment at the end of the meeting, we do reserve 10 minutes at the end of the meeting for public comment. If you're in the room today, please, Michael, do you want to just raise your hand? Please let Michael know if you want to make a comment at the end of the meeting today. If you're on Zoom and you would like to make a public comment today, please send a chat to Michael Anderson Nathy, and he will let me know. I'll take as many people to make public comment as we have time for. Okay, let's just move us along here. See if I'm missing. And we do have ASL interpreters today. I need to go over to my computer after I'm done talking for a second and turn those on. In fact, I should do that right now. We have Jackie Bruce and Catherine Thomas as our ASL interpreters. Actually, I think we're okay right now. Let's see. All right, I think that is it for our etiquette. So if you don't mind advancing the slide. Oh, yeah, thank you. Yes. And if anyone needs to plug in their laptops, if you're in the room here, there's some power strips under the table. They actually came by. Liz made sure they came by and added some power strips, so you can go ahead and plug those in. Okay. Actually, I'm going to. Oh, yes, Bipasha. Yes. Bear with us just a second. You got it? Okay, this is the Wi-Fi. Thank you, Ty. Yes, Liz is reminding me of all the things I need to remind you of. People in the room, if you parked at the hotel across the street, we have passes for you to get out of the garage. So please come see Liz in the green shirt over here. She will give you those passes. Okay, so is Representative, oh yes, yes. Representative Dent, do you want me to stall a little bit or would you like to do your words of welcome? Do you want me to stall a little bit or do you want to jump in those now? Do you want me to stall for a little bit or do you want to do your words of welcome? I'll give it to you right now since I got you up. Okay, let me just ask Chloe to take down the slides. Okay, great.
Thank you, Jamie. So thank you everyone for being here and for participating in this very unique, very difficult panel. Senator Warnick is my seatmate, and she wanted to be here today, but she couldn't make it work. We're at a particularly busy time right now, and I'm not sure why, but we're just overwhelmed with things to do. And I will leave early because I need to be in Stevenson, Washington, which is right across the river from Hood River, for a banquet tonight. So it's a ways to go. Fortunately, I have an aircraft, so I can get there quicker. But you know what? I want to just say something. I have a lot of passion for this. You know, for the 988 line, for suicide prevention, for mental health. I do. And I'm going to tell you a little story. On November 21st, 1924, my grandfather went out to do chores. And when he didn't return, my grandmother sent my dad out to get him, see what was up. And he found him in the barn. And it was ruled a suicide. Now, this is 26 years before I was born. That affected my life. It changed the 7 kids in that family's lives forever. From one act. They didn't know what to do with it. So it passed down to all of us kids, right? And all my cousins. Nobody knew what to do with that. But it affected us because of how it changed their lives and the anger they must have felt and the challenges they had going forward, trying to make it. And then a depression came, and it was even more difficult. And I'm telling you this because I feel blessed because I knew there was something wrong, and I knew that I could be better than I was. And I found people to help me, and it was a kind of a process, and it took years, but I was able to understand the challenges and the problems that was just given to me from my dad and my uncles and my aunts that went through something that I didn't have to. And in 1962, my father's had an employee, the employer he worked for, and this motivated me to change a lot, but he took his own life, and my dad found him. And so I rode with my dad in this old Chevrolet car that he had for a work car, and we went to the funeral, and the only time that he ever opened up about the pain around his father and his boss that had just taken his own life. And that's what started my process of realizing there's something wrong here. I don't have to do this. It took years, but I got there. But what I'm asking of you, and I told you this story because I want you to know how real it is and how dark it is for some people that get into this stuff, and how hopeless, how totally hopeless they feel with no way of moving forward. And my hope was with our crisis line, and I've talked about the agriculture line, being specific, is how we can touch those people and really feel what they feel. So we can hug them. Maybe it's just only over a phone, but we can let them know that we really care and their life matters. It matters to me. And I don't know if I call this a blessing or not, but 2-3 times in my life I've had an opportunity to help someone who was in really deep crisis. And one of them was just laid on my heart to call her. So I called her, and she was sitting in a chair holding a pistol. And she says, "Oh my God, Tom, this is what I'm doing." No. I love you too much for you to do that. And we talked for a long time. This was about 6 years ago. She's doing well. if you want to know. She's doing well. But you know, sometimes that darkness takes over, and we just need that lift. And you know, I just have a big passion. If we can find some kind of a way to make this work, you know, then I'm in, and I want to do that. But so with that being said, I just encourage you to you know, walk a mile in their moccasins, and that's what we're talking about with the ag thing. Walk a mile in their moccasins so you can understand how you can help. And if you don't know what their journey in life is about, it's pretty hard to help. And I think that's what we're looking for, what I'm looking for. And any way I can help get us there, I'm there. At the meeting we had up at Frontier, there was someone kind of mentioning a little funding needed in the meeting. And Representative Orwell and I were kind of communicating back and forth, and maybe there's some opportunities there, but it's all about reaching out and just giving them that hope, you know. And so anyway, this is a tough subject, it's a tough committee. Thank you for serving. I thank each and every one of you for being part of this and for participating in something of this magnitude. And I know it's not the most happy welcome speech you ever heard, but I want you to know I'm really, really, really glad you're here. And those that are online, I'm really glad that you are here as well. So thank you.
Thank you, Representative Dent. I think that was a perfect welcome speech. I know we're running a little behind, so I would like to go to our personal story before we do the agenda and all those other pieces, if that's okay. Lavani? Yeah. Oh, wonderful. Okay. Really quick, though, I did forget to say, and I should have said this, we actually had some more questions from the CRIS for the panel, and I didn't even ask the folks in the room what your questions were. So sorry about that. We probably could have done a 2 or 3 hour panel. But what I'd like to do maybe is take your questions, if you have them, if you want to write them down before the end of the day, and then I can share them with Representative Dent, and maybe if some of our panelists want to offer some responses at their convenience, we can get those back to you. I think we're working on that with the substance use disorder panel that we had last month. So we did have quite a few questions from the CRIS that we didn't get to. So like I said, I'd like to turn it over to our personal story today and to Bipasha Mukherjee to introduce, and then we can go into what the rest of our agenda is for today. So Bipasha, take it away, please. That's the one, yeah. I can hear you.
Is this good? Okay, perfect. All right, folks. Lavani.
It's very quiet, Bipasha.
Lavani is originally from rural Montana. Her experiences growing up in a tribal rural area grounds her in creating more support and resources in rural frontier and tribal areas that are often forgotten. The lack of resources in these areas plays a role in people cycling between poverty, addiction, the law enforcement, mental health struggles with sometimes no break. Her lived experience fuels her passion for helping people who are incarcerated, finding housing and skills that will help them transition back to life outside. Based on her past experience, she launched and is developing her own business, New Visions Reentry. She works as a housing diversion case manager at Northeast Community Center as well. She has an educational background in social work and psychology. She's also certified peer counselor and helps HCA to develop curriculum for the state's peer program. When Lavani is not working, she loves to ride her motorcycle, bead, crochet, and spend time with her 2 sons. Her coffee order on a cold day, by the way, is hot, dirty chai. It said chai tea. I'm Indian. I cannot say chai tea because it's like saying tea. I just can't do it. But I get it as an Indian, what you all mean. Tea comes in various forms. Chai is one of the ways in which tea is consumed. And finally, Lavani deeply believes healing is possible. Thanks, Lavani, for being willing to do this. Yes. And it's your mic now.
Thank you very much for having me. This is a subject that's dear to my heart. I grew up in a little town called Fort Tyne, Montana, in northwestern Montana, on 1,500 acres. No running water, no electricity till I was 12, so no TV. But I had a great childhood initially growing up. Single mom. My mom ended up getting into drugs and alcohol, and that kind of changed. She moved us to the Flathead Valley, Kalispell, Montana, and that's where I grew up part of the rest of my time. In growing up, I learned all the values of small towns and how neat and how connected they really are. By the time I was 12, my mom was in full addiction herself. She had boyfriends in and out, and I left home by the time I was 14 years old. Ended up getting kidnapped at 14 years old on the streets of Kansas City, Missouri, and was found 3 days later in a ditch. That event right there really transformed my life. I didn't know at the time that that's what was happening, but it did. So by the time I was 19, I had my first son. And 23, I had my second son and my first felony conviction. I started using drugs at 19 years old. And the reason why I used them is because I was hurting. I was having extreme PTSD symptoms. I was having extreme panic attacks, and I couldn't figure out why. I was having dreams at night. I had pushed all of my trauma out of my brain. Nobody ever told me that I was normal to feel how I was feeling. Nobody ever told me I didn't have connection to mental health services. It was the church, or I really didn't have anything else. And since I was using drugs, I wasn't going towards the church. So by the time I was 23, I was living in a little town called Choteau, Montana, which is outside of Great Falls, Montana. And I searched for mental health services. I would drive to Great Falls because I didn't want to get them in Choteau because I didn't want anybody to know what I was going through. I was waitressing. And I was a single mom of 2 boys. That didn't last long because I didn't have the time. I was working 2 jobs and had 2 little boys to care for. And so they would give me some medications, but I didn't get any counseling of any sort, nor did I have connection to any counseling. I didn't have somebody to come alongside me and take my hand and as a peer, as somebody that's walked through it, I didn't have anybody that I really trusted my deepest, darkest stuff to talk about that trauma to. And I just didn't know. By the time I was 28 years old, I tried to commit suicide in this town. I did. I woke up with the sheriff and my dad standing at the end of my bed after I'd taken a bunch of Valium and drank a bottle of alcohol. And felt nothing but shame. So in my dad's eyes, I just needed some treatment and straighten up. And the church's eyes, I was sinning too much. So it was stigma after stigma after stigma. So I went to treatment, and that didn't last long because I never had addressed my trauma ever. By the time and then after I kind of straightened up for about 10 years or so. During this 10 years, I went and got my education, raised my kids, and then they moved out. And I was back in this trauma state, and I couldn't figure out what was going on with me. I still hadn't addressed my trauma. I started doing drugs again and dealing drugs on the reservation. As a little throughout my childhood, I bounced back and forth between my mother and my father. My father was Native American and all my brothers and sisters are Native American. So I bounced in the summer times. I'd go between the Blackfeet Reservation, Fort Peck reservations, all across the High Line of Montana. So I was comfortable as being white on the reservation because I grew up there. I started dealing drugs there and ended up with my first with a federal conviction. I spent 5 years in federal prison and was supposed to be released back to Montana, but there was no aftercare program for me there. During my stay and my incarcerations, I started noticing something in small. I started off in Cut Bank, Montana, and got around to a few of the county jails and got to experience federal prison in 3 different federal prisons in all sides of America. I noticed something. We incarcerate more from rural America than anywhere else. While I'm sitting there, they use jail as a mental health facility. We incarcerate. I was looking at the statistics just for Washington. They were kind of mind-blowing. For Spokane, we incarcerate about a little over 5,000 people per 100,000. And for our surrounding counties that are smaller, it's almost double that. And they have less crime. There is something missing here. What is missing? There's a missing piece of connection, connecting us to mental health services, behavioral health services. We need people in the community that have had lived experience, that live in those communities, connecting from the crisis response people back to the communities, walking hand in hand with people because they know the cultures in each community is different. For me, if I would have had that, I would have never tried to commit suicide. I would have dealt with my traumas. The other thing is resources. We put all our resources into urban communities. Rural communities get left out because there's not enough population. Unfortunately, this is what's fueling our prison systems, number one. For small petty crimes, my passion is number one, stopping people before they go into the carceral system through trauma services, through behavioral health services, prevention at the school, in the schools, providing community for these children to have somebody safe to even go to. All throughout my life, I could talk about trauma after trauma, but it could have been prevented. It could have been stopped. How? Through connection. That's simple. Build relationships. Bring in people that have lived experience, that have trained, that know the people in the community, and your outcomes are going to improve every single time. One last thing, because I could talk on many subjects. If we don't start looking at our incarcerations in rural communities, I've done reentry here for the last 6 years. And I have had the privilege of working with people coming out of the prison systems from all over the state. And most of them come from rural communities. They come here because there's no clean and sober living houses in rural communities. We need clean and sober houses in rural communities. It isn't that much to get one going, and we could use peer services to run them. It won't cost that much money. Actually, it would probably make some money. People coming out of our incarceral systems get 6 months worth of their rent paid when they're released if they don't have any money for the first 6 months. That enables people that are doing foundational community services for supportive housing and supported employment services to be able to work with them and get them housed and get them employed and get the next person out. There's many different models that we could use for this, but they just need clean and sober houses. They need services and they need people to connect them to it that lives in the community. Thank you for having me.
And I think you're on mute.
Sorry about that. Thank you so much for sharing with us, Lavani. I'm so glad that we were able to have you there in person today. Your story is so poignant for the conversation that we started earlier in the day about the unique needs of people in rural communities. Your story brought up a lot of the things that our panelists have mentioned about the lack of resources in rural areas. And you brought us to another big topic that doesn't often get mentioned, which is the carceral system and how our mental health system diverts there when there aren't enough resources to help folks before they enter the carceral system. So again, thank you so much for coming and speaking to the CRIS.
Lavani, thank you for that. Really, I'm grateful for you being here in person. This is special for us having you here in person with us. You're welcome to stay as long as you want to, and there's also food. Now we're really delighted to have you here. Yeah. Yeah, let's do that. Okay. Chloe, can you go ahead and put the slides with the meeting agenda pieces on? Okay, so our objectives today, as always, and perfectly just right after this, grounding our work in the personal stories and experiences of people who encounter the crisis response system is our first objective today. We did get to observe and learn about a local crisis care system that fully integrates services across the crisis care continuum with that tour of Frontier Behavioral Health. Is Jan still here? Okay, I wanted to thank her for that, Deb. And then we also learned about the unique needs of rural and agricultural communities when it comes to behavioral health and crisis response with the panel that we just had. So now we're going to tackle the remaining 4 objectives. First of all, we're going to do our updates and learn not so much about from the state agencies. Sorry, I'm skipping ahead here. We are going to learn about how state agencies have considered and advanced your input on meanings and metrics that emerged from the February CRIS meeting. So I don't know if you remember, but 2 meetings ago, we spent time on meanings and metrics, and our state agencies have spent a little time with that. They're gonna talk to you about that today. And then our main discussion is going to be identifying remaining gaps in the discussion of system performance, meanings and metrics. That is a mouthful, especially considering what we've learned about substance use disorder and rural and agricultural communities since we first discussed this topic in February. That's going to be the main body of our discussion. We'll confirm action items and next steps and hear public comment. So I'll just quickly take you through the timing of the remaining of the meeting. If you could jump ahead, Chloe. All right, so we've kind of shifted things a little around a little bit. I think what we'll do is we'll do our system updates and Q&A, and then we'll take a break, and then Tisha and Michelle, we can do your presentation after the break. Is that okay? And then we'll go into our discussion. We'll aim for action items, next steps at 3:45 and public comment at 3:48, and get everyone out on the road again at 4 o'clock. So I think that's it for the agenda. Right now I have 1 person signed up for public comment. So I'll make sure we reserve that time. And now I'd like to move into our updates. So it's been only about 3 weeks since we last met. So there's no, you might have noticed in your monthly newsletter, there were no state agency updates. The focus was primarily on legislative updates. So I do want to offer some time to take questions on that. But before I do, I wanted to give Bipasha and Kristen a few moments or a few minutes to talk about an update on the Lived Experience Stories project. So Bipasha, Kristen, should we put your slides up?
Yes, please.
Okay.
Chris is taking this one.
Hello, everyone. I'm Kristen Wells. I use she and her pronouns. You can't hear me?
Can you speak again, Kristen? We didn't hear you very well.
Yeah. My name is Kristen Wells. I use she and her pronouns. I'm one of your lived experience representatives on the CRIS. I've been working with some of the other lived experience representatives and HMA on this lived experience stories project. We've talked about it a few times before, but our update for you today is that we're going to be focusing on the broad outreach to all populations this year and hoping to do a deeper dive with individual interviews next year. So for phase 1, what we're looking for is people who have contacted or engaged with the behavioral health crisis system within the last 2 years, and that's any part of the system, calling 988, calling a local crisis line, going to an emergency department, an interaction with a DCR, anything like that. How we'd like to do this is we're going to be gathering stories in writing, in video, via audio, and by partnering with agencies that work with some of the communities that we don't hear from as much, to have them do the questionnaire with folks in person, since not everyone has easy access to a computer to submit their story. We're working on the story prompts and the demographics we want to gather so that we can make sure we're reaching every community that we can think of, ideally, but also especially communities that aren't able to come to our regular lived experience subcommittee meetings. Online meetings on a Monday afternoon are just not feasible for some folks to attend. So there's definitely a lot of people we don't hear from. We are ensuring that there's compensation for people's time and emotional labor. We're working on our budget to find out how much we can compensate participants. And again, we really want to outreach to communities who we might not otherwise hear from, to hear stories that we're not already hearing, in addition to the ones that are really important for us to hear that have been here so far. I'll pass it over to Bipasha.
Chloe, I don't know, could you hear it? Next slide, please. Bipasha, you might need to pull the mic a little closer to your face because of your mask.
Okay. Oh, okay. Yeah. All right. So basically our ask is any of y'all on the CRIS, if y'all could reach out to HMA, if y'all have any knowledge, expertise on doing a project like this well, I for sure don't have it. And if you know someone who does, I think our biggest concern is people who are already often heard from will be the only voices we hear. Their voices are important and valuable, and they are not the full picture of what is happening in the behavioral health crisis response world. We need to hear desperately from those who can't or don't show up to our monthly Monday afternoon meetings, and people who live on the outsides of main circles, and especially people who live on the margins, are often forgotten, and we need the behavioral health crisis system to work for them the most. Once we get the form, I don't know what else to call it, but whatever we put out into the community with the prompts and the demographic requests, I think we agreed that CHMA will send it out to the CRIS for input. So please take a moment to read that so that our initial ask when it goes out to the community is strong. Please also spread the word about this project within communities y'all have any interface with. We know some of y'all on the CRIS work for agencies that might interact with populations that are not often heard from, and we would like to get tap into those populations? Can we reach them through their case managers? There's no way for us at this point to know how big the response will be. And if we get a huge one, though, we will need your support to ensure people are included, supported, and fairly compensated. HMA, thank you, HMA, is working with us to see how they can financially support this project, but we will also have to see how things unfold. We'll keep you informed along the way and hope the project will get the support it needs so we can go broad and deep, but above all, that we can yield valuable data that can inform this continuum that we're all kind of thinking about to build it out efficiently, soundly, and inclusively. And in phase 2, so in our discussions, we realized 2 things. Really, the devil lies in the details. It's not enough to say, hey, you called the crisis line on 988, what happened? It's important to follow the thread of that crisis, sometimes across multiple calls, multiple agencies. So we may need to follow up and interview people who have submitted a story to get a deeper understanding. And although we'd love to, we feel our initial broad ask may not capture some of the most marginalized people. So we will need to make an extra effort to get to their stories. Both of these things mean deeper dives and following up on what is generated from phase 1. But we know that there are changes coming to HCA. It's moving from BHI to, changes coming up in the CRIS where it's moving from BHI to HCA. And it's a heartfelt request that the CRIS please consider supporting this project next year as well, so that we can get the data we need to really build out the system. Thank you.
Thank you, Kristen and Bipasha. So now I just want to open it up to the CRIS to see if you have either questions for Kristen and Bipasha about the Lived Experience Stories Project, or any questions from reviewing the newsletter this month on the legislative recap. And I think Representative Orwell is available to maybe jump in and answer some of those questions. So CRIS members on Zoom, if you could use raise your hand function or send a chat to Michael Anderson Nathy if you have a question or comment, and CRIS members in the room, if you could just turn your table tent on its side if you have a question. Darcy.
I do have a question. This sounds great. Excited to see what happens. Have you thought about, once you are successful with the project and you have the stories, how you're going to use the stories?
I think the goal, and maybe Michael Nathy Anderson, you want to take that one on?
Sure. Our plan is to do an initial review and kind of theming of the stories, kind of looking at successes that might be replicated, and then gaps or failures that we can capture. And then we'll be sharing some of those themes in our work group with some of the call centers and state staff to try to come up with some recommendations. And we'll also be sharing those with the CRIS, I think in August is our hope. Start sharing those to also help us identify things that we might do to address those system gaps.
Okay, it's Michael Anderson Nathy. Sorry about that.
And also,
I know
encourage you to
also
think about, how to share the stories more broadly to the community.
Yeah. That would be good. I mean, and it's not data that just needs to be used for the CRIS process. I'm hoping it'll get housed within the government to different projects can access this. And that's how we maximize the impact of data rather than repeating the same thing again and again. And if there is data housed in the government that already has some information, I'm assuming that's coming into the CRIS so we can hear about what's already been collected in terms of people's stories. And like we always say, one way to measure when we get to how do metrics is to get the voice of the community that is using the service to tell us what they feel is happening.
And Kristen, were you going to jump in there?
Yeah, one of the things that prompted this project was getting into the details of a story with a member of the subcommittee. We were really able to identify what specific thing happened that didn't match what was supposed to happen. So that's one of our big hopes for collecting the stories, is being able to compare what people are actually experiencing to the way that the system is supposed to work or the way that we want it to work. That way we can identify specific mechanisms that aren't serving people correctly. So we think there's a lot of power in stories for us to see how the system is actually working in real life for the people that it's supposed to serve, in comparison to what the guidelines and procedures of these systems say should be happening.
Pasha.
I had a question. In the updates, Senate Bill 6251, what is community-based crisis teams?
Does anyone, Representative Orwell, does anyone else know how to answer that question? What is community-based crisis teams, as it was called out in the legislation?
Yeah, and I'm assuming we're talking about the legislation in the previous session. And sorry, my computer's about to force an update, and I don't know how long I have. So those were, teams that can do a rapid response, and there was an incentive program for those that can respond within certain timelines, but they have to be a clinical team with not with law enforcement. So they have clinical staff, they have peers, they could partner with EMS and fire. But again, the model was it was a kind of clinical mobile team. And again, it might look different in different parts of the state.
Wait, I have a follow-up. So how is that different from the MRSS or the mobile crisis response? I guess that's what I'm not clear about.
Right. Well, the hope and goal of the bill is that we can have an alternative to the police, but to have an alternative, it needs to be able to rapidly respond, especially in urban areas. And so we use some of the 988 fee to actually provide additional dollars for these teams that can respond more quickly and to focus on 988, right? There's a lot of mobile teams, they do a lot of research, a lot of responses, but we can't necessarily have the money to have every team in the state be a rapid response immediately. And so the goal was, how do we create the 988 system and make sure that that small percentage of calls, which is what, like 5%, that need a rapid response will get that rapid response, and that it would, in every case possible, be clinical, so that when people call 988, they see that, really the goal is a clinical non-law enforcement response. Does that make sense?
I think you can see her nodding her head, probably. Yes, the camera's on her. Okay. Any other questions or comments from the CRIS on either the presentation from Kristen and Bipasha or on the legislative update?
I'll just mention in the chat that Kashi has offered to help recruit stories from children, youth, and families, and we'll reach out to you, Bipasha and Kristen, and also encourage us to, if we do want to consider using the stories beyond CRIS, that we need to make sure we include that in the informed consent. And so just bringing that voice to the room.
That is wonderful news. Thank you, Kashi. Okay, I think we're going to go ahead and take our 10-minute break now. And when we come back, Tisha, oh, sorry, do we have another comment?
Yep, Dylan has a question. To clarify, the responding teams are partnerships with EMS, fire, or behavioral health only. No EMS or fire, but not police. Is that right? Yeah. To clarify, the responding teams are partnerships with EMS, fire, or behavioral health only, meaning no EMS or fire, but not police. Is that right?
That is correct. And we can send the text from 1134 out to the CRIS group. Again, it doesn't mean that a mobile team wouldn't choose to include law enforcement if there was a weapon or a reason, but the base teams that we're setting up here to respond to 988 calls will be non-law enforcement.
Any other questions or comments? Okay, I do want to make one comment too. As I mentioned earlier, we have one person signed up to make public comment. So guests, community members who are joining us today, either in person or on Zoom, if you would like to make a public comment, if you're on Zoom, please send a chat to Michael Anderson Nathy. We will take your name down and I'll call as many folks in the order in which they've signed up as we have time for. If you're in the room, Michael's over here. Please let him know and he'll add your name to the list. And now I think we're going to take a 10-minute break. So I have, let's just say 2:10, I'll round up. Let's all be back on camera and around the table at 2:20 when we'll hear from Tisha and Michelle, and then we'll do our discussion. So see you all in a little over 10 minutes.
By the way, I'm not days and I was never interested to people. They were like, "You're good." Thank you.
But she, in her email, it was Christy.
She's dealing with a lot of issues with 12 and under. Oh, this side of the and this year in
Yeah, it's yeah, we'll be there. Yeah, ours is Mark would play
Okay, everybody, I think I'm going to get us going again. So if you could all make your way back to your seats, please. And Chloe, if you could advance the break slide to the next, perfect. Thank you. Okay, we're just reassembling here in the real room, or not the real room, the actual room, not the virtual room. Okay, so next up, I promised you a presentation from our folks at HCA and Department of Health, Healthcare Authority and Department of Health, that to let you know what they've been doing with the meaning and metrics work that you all produced back in February. And to accompany their presentation, I have printouts from the documents that Nicola sent out. So I'm going to go ahead and pass those around while Tisha and Michelle are presenting. And Chloe, if you could put their slides up, please. All right, fire away.
Great. Okay. Is this working? Are you hearing me? Okay. It's hard to hear when you're, I saw Bapasha struggle with that too, but anyways, good afternoon, everybody. My name is Michelle Roberts. For those who I don't know, I use she and her pronouns. I serve as the Assistant Secretary for Prevention and Community Health at the Department of Health. And our team has kind of support for the first stage of someone to contact and support to the 3988 call centers in the state. So what our teams have done is have looked at all the list of metrics that have been created collectively. And then in some of the documents that are being passed out and that were attached in the meeting invite, you can see more detailed information on what's happening at each of our agencies, on what we're already measuring, and some hopes and dreams we have about what to measure in the future. And in these slides today, we're going to kind of give a little bit more of a higher level. So if you want to see the specific details, look at the handouts, but Tisha and I will kind of walk through things at a higher level. Is this the first slide? Hold on one sec. I'll make sure I'm in the right place. Okay, I'm still in the right place. So as with all measurements and metrics, guiding principles are really helpful. So we're going to talk about our alignment and a path we'll take to make sure we incorporate the CRIS Committee's feedback into our data strategies. As we incorporate feedback, we'll continue to remain vigilant on our foundational aim to provide a safe place to call, a safe place to someone to respond, and a safe place to go. So with that, can we go to the next slide? And I'm going to turn it over to Tisha. We're going to go back and forth today.
Well, good afternoon, everyone. I'm Tisha Kirschbaum with the Healthcare Authority's Division of Behavioral Health and Recovery. I am the Division Director and really excited to be here this afternoon. Michelle said this, but I want to echo our thanks to the CRIS Committee and the work that you did. I believe it was back at the February meeting to kind of pull together to talk about these guiding principles and the ideas for metrics and measurements. It has been really helpful. So you guys were able to do that brainstorming and you really identified, pulled together 10 guiding principles that our teams have then taken back to kind of review and analyze. So as we were looking through these 10 principles to better understand their aim, their alignment, feasibility, we looked at like what we're doing currently, near, and like future states of data collection. Great news, our team discovered that we are in alignment with the CRIS committees on the importance of these guiding principles and their meaning. We also evaluated the recommended measures and considered these within when we started to think about what's our path forward. So with the foundational aim always of providing a safe place to call, a safe person to respond, and a safe place to go, we've categorized the guiding principles and potential measurements into current, near, and future states, which correlate with the planned rollout and phases of the 988 supporting system and platform. Can we go to slide 3? Awesome, thank you. So in our review of the CRIS recommendation, we recognize that the principles, meanings, and measurements kind of generally rolled up into 2 categories. The first category focuses on ensuring the safety of those seeking help from 988. The second focuses more on the efficiency and efficacy of the system that supports 988 staff and help seekers alike. So within these 2 categories, there's countless opportunities for measurements to take and metrics to build, probably more than we could ever accomplish, but it's such a great launching off place. So keeping our foundational aim in mind, we mapped out the current, near, and distant states for measurements and metrics related to each guiding principle. By doing this, we began to see a roadmap of what reporting the CRIS Committee can expect at different stages of 988's evolution. So this roadmap exercise we found really helpful, and we can see that some data elements will be available for measurement sooner than others. However, that does not mean all elements within the guiding principles will be available at the same time. So for instance, the guiding principle, the crisis response system is empowered by technology that is accessible to all, includes several metrics that will not have measurements until a system is selected, and in some case, until the system is built. So for that reason, the guiding principle is viewed as a distant state. However, we can compare the key measurements of call, text, and chat volumes against population awareness to understand and predict resource requirements for crisis counselors and crisis centers. So using these 2 measurements, we began to form a metric. How many people do we need working in order to meet our 90% goal of in-state calls being answered in-state? And now I'm gonna hand it back over to Michelle to take a look at what early call, text, and chat measurements look like today.
Okay, so the slides so far have been kind of grounding in some of the big principles of how the lists and the ideas compare to what we're doing or what we hope to do in the future. And the next 2 slides, so if we can go to the next slide, are going to have 2 examples of data and metrics we have now. So one of the places where we have consistent measurement, and there is lots of room for improvement, I'll say, but we do have a lot of measurement right now around call, text, and chat volumes that are coming into 988. Each of these measurements allow us to understand the current situation, given where awareness is for 988. As you can see, this relates to empowering technology that's accessible for all. So, because we want every person to be able to access 988 in the way that is best for them. So some people that may be by phone, some people it may be by chat, and some people it may be by text. These are the metrics we can report on today, but in our kind of distant future state, more information on accessibility will make it possible to form more robust metrics and enable us to set more ambitious goals related to accessibility. So those could include things like language access, which we've talked a lot about at this table before. Today, our goal is that 90% of in-state calls, texts, and chats are answered within our state. Our 12-month running average for calls and texts is 89% and 86% for chats. So on December 18th, the general awareness campaign launched at the national level using SAMHSA materials. And from that point forward, we want to measure how awareness is also impacting call volumes or call chat and text volumes. And you can see that green area for when some of the national campaigns started. So there's a lot more work to do here, but this is just one example how the CRIS guiding principles will influence how we approach measurement and metrics. And our last slide, I'm going to hand it back to Tisha to talk about some other current metrics that are happening.
Thank you. Can we go to the next slide, please? So in order to measure whether or not our system is centered on and informed by lived experience, we look to the CRIS Committee for guidance, as well as alignment with our national best practices. So on the slide here, you see some information about some trainings that we have completed. So these crisis intervention trainings, we really focus those trainings on aligning with SAMHSA's core competencies. So for these trainings, mobile crisis teams who are contracted with the BHASOs, or the Behavioral Health Administrative Service Organizations, are trained on trauma, care, and de-escalation techniques. And one of the areas that staff reported who'd taken these trainings that they found extremely helpful were techniques on harm reductions, which helped them feel better equipped to support people who are experiencing co-occurring crises. So far, we have provided 3-hour-long trainings to 358 team personnel, and additionally, 193 team personnel completed a 4-hour training focused on youth. So again, we want to thank you for your recommendations, and we're very interested in taking your questions, and hopefully this information was useful.
Thank you, Tisha and Michelle. So now is an opportunity for our CRIS members in the room and on Zoom to ask Tisha and Michelle questions about their presentation or offer any comments. Chloe, can you take that? Perfect. Thank you. Any questions or feedback? Oh, yes. Thank you, Darcy. I see you.
I have a couple questions. One is related to the presentation this morning at Frontier when they were talking about the 988 911 diversion. Are you going to be able to collect any data in regard to those calls? Were they able to divert them from an ER or potentially jail as a result of the 988 instead of 911?
Yeah.
Michelle, sorry, for those folks who weren't at the presentation, could you just set up the
Yeah.
to explain what? Yeah.
Yeah, so Darcy's question is about work that is just starting that we're calling 911 diversion. So it is about each of the 3 call centers in the state. We received funding actually 2 sessions ago to start a pilot project in each call center between a partnership of those 988 staff and a 911 call center in their area. So the first kind of 6-8 months was a lot of planning, and now each of the 3 call centers has a live partnership happening where they have regular connections and are building trust. And in fact, having a lot of calls from 911 that are behavioral health that are not needing immediate law enforcement or first response are being transferred to the more appropriate response for 988. So it is really exciting. I know all of us have had a vision for this for a long time, and it is starting and happening. So we are doing a lot to collect data to be able to report out. So what I can say right now, I don't remember all the different metrics of that. I'll see if we can make sure we have some more information about what's being collected. There was a baseline survey of the partnerships that the data is kind of coming in right now, and our EPI staff is working on that. And then each of the call centers are reporting on some metrics regularly so that we can really, hopefully, the goal always with treating this as an initial pilot was to be able to help tell the story and then also help us build from how can we continue to expand and think about what this looks like statewide. So lots more to come, but that is happening.
Okay. And then I have a question on your slide about the number of calls.
Mhm.
There was the kind of orange that was I think it was like in-state calls, and then
Yes.
blue was received calls. Or
Yes.
something like that. So what's so it looked like there were fewer received calls than in-state calls. Can you tell me a little bit more about the differences between those two?
You know, I wonder, our DOH staff on, can somebody answer? Do we have actually the calls? The color coding backward on the graph? Because it should be, I think it maybe should be flipped, but our DOH.
Yes. Yes, Michelle, those are clipped.
Okay.
Okay, well, that makes more sense.
Sorry
Okay.
for that confusion. Good editing eyes, Darcy. So what we just realized, if everybody's not tracking, is we have our color coding wrong on the graph. So I am sorry for the confusion. The orange line, the top line should be the calls received. So the total volume of calls coming in from a Washington state area code into 988 nationally. And then how many, the blue line in the bottom is the percent that are being handled in state. So that goal of 90% of them. And overall, we're hovering right about 90% across the board. One of the things that I think you can see more recently, some of the lines starting to come together, is a couple things have been happening, but I just want to highlight them again to kind of brag on the continued quality improvement that is happening with the call centers. But all three call centers are now backup for each other. So sometimes if a call can't be answered in state, it was kicking, and sometimes it can still kick to another state, but each of the three call centers are backup. So that is going to continue to help drive those lines to be closer together, and probably why we're seeing. And also we have at this moment, originally only Volunteers of America was taking chat and text in state. Crisis Connection has rolled on to taking chat and text as well. And then longer term, Frontier will do that work as well. So
we can,
we'll
put the
correct, we'll
corrected
work
slides
to
for the
make
ones
sure we
online.
get that
Yeah,
corrected.
that's perfect. Thank you for catching that. There's a hand up from Kashi and then Dr. Snowden. Kashi?
Thank you. Question for you all that related to that graph, but you don't have to put it back up. Can that be broken down by age, and can it be broken down by race, ethnicity, or language of care? I know that demographic information is not required for the use of the service, but do we have a way to say definitively, if we know this is a youth caller, how many calls, texts, or chat come from youth, and then race, ethnicity, and language?
That is not easy to do right now, but it is one of the goals of the future state. And one of the reasons for when we have our own data system within the state, tracking calls and details. And like you know, Kashi, we can't screen initially for those things, but we can collect data elements as they're being gathered. But part of needing a statewide system, and one way to track the data is that then we'll have the data comprehensively together, and each of the three call centers kind of collects that data in different ways and have different capacity to do those reports. So definitely a future state goal.
Thank you.
Dr. Snowden.
Thanks. In one of the slides, you had tallied up the number of metric recommendations from the CRIS, and I think you said it was 39, and then you talked about 14 of them, there was sort of no plan to follow up, and then that 7 were technologically challenging. And so I wasn't clear if all of that fell into the same bucket as the example you gave about how you can't know that the technology is feasible for everybody until it's established. But what's going to happen with all of those that are not planned for or are technologically challenged?
well, the technology one is about, and this, the state is in the process of doing assessment about our technology to have a comprehensive system or several comprehensive systems that talk to each other seamlessly so that no matter how somebody's entering, can their data be collected and can it get to the other partners within the system in one way, and people can add their information and track, and we can have the right reports. So that's when we say the future state and the significant technology dependencies really mean that we can't do that work till we have that technology system in place. So that's kind of what I'll say about that piece. Do you want to say anything else about
For the 14, where it simply said there was no plan, I don't remember your exact language, but the way I interpret it is that there was no plan to follow up to do it.
So I would describe it, I think we probably weren't as clear as we could be there. So when I read that, or the point that I was hoping to communicate is more, I think we need to continually assess as we build out this system, are there some of these metrics we might not be able to track now, or a way to do that? And is there, as we build out the system, we need to keep on looking back and say, is there a way that we can do it now?
CRIS members on Zoom, or let me check with Michael. Any chat questions or comments? Okay. Looking for raised hands. Any other comments in the room or questions? Okay, then I think we can, thank you, Tisha and Michelle. I think we can move into our next agenda item, which is getting prepped for our discussion. So what we want to do here, so back in February, we spent our meeting focused on identifying what we really mean by the vision that we articulated in our first year together, and what those meanings are of each of those elements of our vision, and then how would we measure when we've achieved those. And so that is the document, one of the two documents that Nicola sent out to you. I can't remember what it's called exactly, and it's, let's see what's named, the summary of metrics identified by the CRIS. And you also received an inventory of current crisis system metrics. The summary of the CRIS committee discussion and input on system performance is the document that I just handed out, and Tisha and Michelle, I have your copies. I'll bring them over to you. You might have them electronically too, but we thought it'd be helpful to have a printed copy in front of you. CRIS members on Zoom, you received this by email. You also received 2 prompt questions to think about in advance of this meeting. What gaps remain in these documents that still need to be addressed? And an example that I noticed when I was going through is that we have several meanings in there where we haven't identified associated metrics yet. So that's an example of a gap that I saw. And then the second prompt question was based on the presentation at the March CRIS meeting about substance use disorder. What additional meanings and metrics should be added to adequately address substance use disorder or co-occurring mental health crisis and substance use disorder? And I'm going to add a third prompt question. I promise we'll put these up on the screen so you don't have to remember them. I'm going to add a third prompt question for you, which is just like the one I just read to you. But what additional meanings and metrics should be added to adequately meet the needs of rural and agricultural communities based on what you learned today? So I want to give you actually some time to think. We're not going to do breakouts today because it's just way too complicated to try to do that in a hybrid setting. Instead, what I'm going to ask you to do is spend the next 15 minutes or so looking at that document that came from the work you did in February and thinking about those 3 prompt questions. I have notepads for you. I can pass them around if you want, and pens. And I want you to just start writing down your answers. Just giving that some thought, and then we're all going to come back together and have a group discussion. So looking at the time here, it's 2:42. So let's just a few minutes, like 2 or 3 minutes before 3 o'clock, we're going to dive into our discussion. Are there any questions about what I'm asking you to do? Chloe, can you put the slide up that has the prompt questions on it, please? All right, while she's putting that up, I will give Tisha and Michelle your printed copies. And again, there we are. So a little bit different order here, it looks like. Based on the panel presentation at today's meeting, what additional meanings and metrics should be added to adequately meet the needs of rural and agricultural communities? What additional considerations would you highlight to address? I did not read this one to you. What additional considerations would you highlight to address the needs of rural communities that have not been covered today? Based on the presentation at the March CRIS meeting, what additional meanings and metrics should be added to adequately address substance use disorder or co-occurring mental health crisis and substance use disorder? And then finally, what other gaps remain in the meaning and metrics document that still need to be addressed? So take the next 15 minutes, and at about 3 o'clock, we'll start having our discussion. Okay, folks, let's take another 3 minutes or so, and then we can start our discussion. Okay, I'm going to ask folks to kind of come back to the discussion. And Chloe, if you wouldn't mind taking that slide down. All right, did everyone in here get enough time to think through your answers? Looks like I'm kind of getting from your body language you did, so yes. All right, so CRIS committee members, I'm actually going to start with that question about what gaps remain. Oh, Michael's going to share a whiteboard here. It's okay. Michael's going to scribe for us. He's just getting that whiteboard up. And Michael, when you put it up, if you could put it on present rather than collaborate. Take your time. It's all good. Okay. So I'm going to start with that first question, which is what gaps remain in these measures and metrics that you want to make sure we highlight so we can potentially continue working on it. What's that? Okay. Well, you can keep working on that and I'll start the discussion. We can catch you up. So CRIS committee members either on Zoom or in the room, who has some answers or thoughts on that remaining gaps question? Oh, sorry, Kristen.
Yeah, so there's definitely a lot of empty boxes under how we're going to measure things. And some of that I think is just finding ways to operationalize the meaning, like to define what the meaning looks like on paper so that we can find a way to measure it.
I noticed that too, Kristen, and I think HCA had done a little bit of looking at those as well, and maybe could use some more clarity from us on what some of those meanings are. And look, there's our whiteboard coming up. Okay, so you want to scroll to the left. Awesome. Michael's going to zoom in. He's going to just start documenting. So in that remaining gap section, Kristen said there were a lot of empty boxes in the metrics. Under the yellow one. And it might be a matter of operationalizing those meanings to know what we want to measure. It's okay. Okay, why don't we just take that down, and why don't you just put a Word document up, and you can just, okay, this is the only tech glitch we've had today. I'd say it's been a pretty good day. All right. So Michael's just going to scribe on a Word doc because our best laid plans with this beautiful Zoom board are not cooperating with us. Alicia.
Hello. My name is Alicia Morales, and I use she, her pronouns, and I oversee an alternative response crisis team in the city of Tacoma, just to say hello. I think from the space that I'm filling on CRIS, the piece that I really want to ensure I'm bringing up every time is the how we're measuring traditional crisis services through like the regional crisis lines or 988 in comparison to those through the 911 system. So I don't really see very much inclusion in terms of how those people are being supported, aside from one measurement of saying monitoring first responder versus behavioral health deployment of appropriateness. So I think, how are we including the 911 response system in the crisis work, and how are we measuring what those outcomes are? Because I think sometimes people can have engagement with first responders and they have an outcome that we're maybe not capturing because we're not looking at the outcome of first responders in comparison to traditional crisis systems. And so that's all I'll say for that. Thank you.
Thank you, Alicia. So I'm hearing that we need to maybe do some more thinking about the measurements for the traditional 911 response system, and in particular the outcomes for people with behavioral health crisis that are accessing it through the 911 response system. All right. Yeah, that would be great, actually. Michael's going to screen share the Word doc so we can, this also just makes it easier for folks participating on Zoom and in the room to track. Except now that I can't, what's that? Okay, the first one was Kristen said there were a lot of metrics that were blank, and we should do some work to, she thinks that it might be because we need to do some work to operationalize those meanings. And I had just had a chat with HCA, and they had done some analyzing of what we had produced in February and said they could maybe get some more direction on those meanings from us. So that, I think, marries nicely. I see Kashi.
Thank you. Alicia did a good job of introducing herself, which I should have done. Kashi Aurora, she, her pronouns. I work at Seattle Children's and represent children, youth, and families needs on this committee. Related to what Kristen said, I had the same reflection that there were a handful of metric cells that were blank, but I did notice that some of the meanings are consistent across multiple guiding principles. So for example, there's one in the 4th page that talks about providers having in-depth knowledge of service and resources and being able to make informed referrals, which is very similar to one on the 1st page where responders know the system and can refer people in crisis via informed referrals. So I wonder if some of these actually do have metrics. They're just not copied throughout the entire document. And I think the other thing I was reflecting on was there are a number of meaning statements, specifically in the guiding principle of crisis response system, that feel very passively worded to me. So it would be hard to create metrics for them because they talk about the system is aware of this, and I really just don't know how you would measure that. I think we need to get clearer on who in the system is aware of racism in healthcare or racism in behavioral health response. So that was my second thing. And then really quickly wanted to thank people for the work of mapping metrics to guiding principles. It's really helpful to see this laid out this way. I think it would be really helpful for one additional column to show if that's a metric Michelle and Tisha, what you were talking about, if that's a metric we currently have or a metric we're planning to have or a metric that for some reason is out of the realm of possibility, and what are the barriers to having those? Thank you.
So some really good stuff in there, Kashi. Yes, I think we can actually go back through this and look to see if some of the metrics carry, because you're right, there was a lot of, when we were doing this mapping, we saw there was a lot of consistency across the guiding principles with the meanings. We can look and see if there were any metrics for meanings that could be replicated where that meaning is duplicated. So that's definitely some work we can do. And yes, I think when I was talking with HCA about some of the meanings that felt a little esoteric to them or they didn't know what to do with it, that might be one of the issues, the one you raised about it not being clear who the actor is there. So that maybe is something we can dig into a little more. And then finally, we actually saw your comment to Michael about that very question about, can we see that column of notes about what we're already doing, what's planning, and what isn't yet possible because of the tech. And I checked with Betsy, and it sounds like that's a work in progress. So, so that will be shared. And yes, that's exactly, I think, was the plan, to put a third column there. So thanks for that. All right. Let's see. I see it. Oh, we have a comment. Okay.
Say more about it.
Yeah. Why don't you circle back, Michael? We saw a note from you in the chat. Maybe you could give a little more detail to Michael and I can read it out, or if you want to speak, you can also raise your hand, just let us know. And I see a hand up from Representative Orwell.
Thank you. It was a little too long to write a comment, but I think it fits with Kashi's remarks. One of the things I feel like needs like a lot more defining and tracking is really the next day appointments. And, next day appointments that are crisis appointments aren't just linking people to services, right? They're that additional intervention for someone in crisis. And when I was listening to the ag discussion, we were kind of, Rep. Dent and I texting back and forth. I mean, there's some great ways to be more sensitive around next day appointments, whether it's someone trained in agriculture, right? That could be doing that follow-up, or, people, multicultural, tailored services, right? For people with different ethnicities. So it just seems like, one, we don't really know how they're working. We don't know how they're working between the public and the private system, and what our system could be doing to tailor it. And then Kashi, your remark about demographics, that might be an area where maybe we could be collecting more demographics, to the point you raised earlier.
Okay, Representative Orwell captured that we are not covering next day appointments, and could add some metrics here around those. So Michael's got that down. It's good. And Michael Robertson, I'm sorry, so did you get any follow-up from Michael Robertson? So Michael, we got a chat from you. I just want to make sure we understand the point. So if you can give a little more detail and a follow-up chat to Michael Anderson, Nathan, I'll read it out. Dylan.
Yeah, it was about, based on the presentation, in additional considerations you highlight to address the needs of rural communities that have not been covered today. Like when I was talking about aid and subsidy to particular farmers and folks in that demographic, that like the people around the panel were explaining their demographic. So, because not every marginalized community gets aid the same way. Farmers get it completely different than, say, someone in the urban sector in a community of color, do they not?
I think that was a takeaway for me too. Yeah, Michael, I think you're
Yeah, and so just wondering how, if that's a consideration when it comes to how people are able to access. Are they doing any better when it comes to behavioral health access as to, say, a community of color that's impoverished? Is it the same? Is what's different about it? And because I know that both at a lower income level, what does it look like? And what things are missing? Are there some similarities, or is there any differences?
Okay, that is
And how do they go about getting that extra income and that subsidy and that aid?
so, and Michael, just to make sure I'm tracking you, so you're answering that other question we asked about additional considerations that we didn't cover today regarding road. Okay, excellent. Thank you. And looks like Michael Anderson Nathy is getting this down. All right, Dylan. And this is back to the question I was asking earlier about gaps in our work here. Dylan, go ahead.
Hi, Dylan Nishimoto, he, him pronouns with Asian Counseling Referral Service. One thing that was coming to me is around, because we were talking about the co-occurring and substance use needs, and I just had a question about how that's being recorded in whatever systems we're using. Is this being identified by the person calling in or accessing the 988 service, or is this being determined by a certain set of assessment questions to do that, or is that being done just by suspicion of whoever is taking the call? Yeah, so I know through other portals we have like point click care, there is chief complaint or visit diagnoses, but to my knowledge that we're not trying to provide a diagnosis at the time of call. So I'm curious about how that's being monitored.
It's a great question, Dylan. So, do any of our state agency folks or call center folks know the answer to that question, how we're determining for a data collection purpose if someone has co-occurring substance use disorder when they're calling for help? Is that maybe something we need to flag and follow up? Do we pass the mic over to Leva? Thank you, Jupasha.
There's currently no clear definition for it. I think each center probably goes about collecting that as part of their, intake or record information a little bit differently as well. So
Okay, so that seems like that would be a metric we would want to formalize a little bit more. And this wasn't specific to SUD, but it's more about how we're identifying the presenting issue for the caller. So we're really working with the caller or whoever's accessing the support that they are defining, or we're working with them to define what their primary need is.
Yeah, and Tisha and I are whispering over here too, thinking about how what we said earlier, repeat what we said earlier about how a future state of one system where all this data collecting and the different levels of people who would be interacting within the system. So I think we could find ways to help refine that for what the call centers may collect, but they may or may not be the ones to know that or collect it. But if it was somebody, let's say, who we sent a mobile team to, they may be able to, then they would have the access to the data that the call center and be able to add in more as they interact with somebody. So I do think some of the technology, what we're working towards with technology could help as well.
I hear Dylan saying that in terms of gaps, that is maybe something that we can work out a little more, at least a process where we also engage the caller in defining what their primary need is. Did I hear that right, Dylan?
Yeah, and also just again honoring the caller and not operating off an assumption with limited information, so folks aren't being labeled in a way that may or may not be accurate to their presenting need.
That's well put.
Thank you.
Okay, I see Darcy.
Yeah, Darcy Jeffrey from Wisha. For those of you on the out there in internet land, I have a couple observations. One is that as I look through this, both at the kind of the meetings and the measurements, we have some very specific ones related to the someone to call, but and there's some generic ones that kind of cover all three, but we don't really have very many specific related to the someone to come and someplace to go. I think we have some gaps and some work to do there. And then the other thought I had is somewhat related to the rural conversation, is that when we look at our guiding principle related to equity and anti-racism, we can expand the concept of equity So we're thinking of rural and urban and maybe age, some other sorts of measures and meanings related to different components of equity.
So I'm going to probe that really quick, Darcy, because when we defined how we were going to center equity 3 years ago, I think we did include all those categories, but it sounds like your takeaway when you're looking at what we've done here is we may be retreating to the more narrow vision of equity, and we need to revisit that. Am I tracking you?
The actual language and the meaning.
Yeah.
We could be more expansive in thinking about that.
That's great. Okay, thank you. All right, I see Claudia's hand and then Dr. Snowden, and then I'd like to move on to the next, and Bipasha, and then after that, I'd like to move on to our next set of questions. Oh, we got all kinds of action. Okay, all right. I'm going to manage the time because I really also want to get into the what else do we need to do here. Claudia.
Claudia de Alegre, Chief of Behavioral Health for CMAR, representing the underserved communities. I think that this one probably touching more number 2 than number 1 question. But one of the things I see for the presentation today, I want to make sure that we really understand how different are the agricultural communities. Just want to make a disclaimer. I come from the owners of the farm workers. So there is a huge community who it represents everything that was given today. Large suicidal ideation because finance issues with the stage of the market, the drop of the milk prices, all of that is super real for the owner of the farms. That's the life of my in-laws because they have farmers in California and they are owners here in Washington State. That's totally different of the realities of the farm worker. So you have a farm worker who is an immigrant, who does not have a documentation to work in this country, who does not speak the language, who work hard and the suicidal ideation is not as high. Very different than the reality of suicidal ideation living by the kids of the farm workers, very high. You have a group of youth who does not have identity, who doesn't feel like belong. They don't see anything in terms of our future, and they had a really high suicidal attempts and suicidal ideation. So our metrics cannot be the same. Among the people in our rural communities is so different among the agricultural community. So I wanted really strong call out. We can now look at because then we start reaffirming the issues of oppression. We cannot look at the owners in the same way we look at the workers. Both are suffering for incredible amount of issues, but they should be differentiated because the metrics and the needs are very different.
Claudia, thank you for bringing that up. So yes, I agree with you. That's actually a really important answer to the other question we asked about what we didn't cover today. And you asked that question of the panel about Latino farm workers and what services were available to them. I think that fits very beautifully with your point here that we really haven't dived into that and we need to understand that better. So thank you for raising that. Okay, I think I had Dr. Snowden up next and then Bipasha.
I was going to jump ahead a little bit, but I think for the basics around rural ag, I think the point Darcy made about including it in the equity section would work, but we also have this section about people in crisis are receiving services that are responsive to their age and culture. And in a certain sense, this is a different form of cultural competency. And I think we could think about it that way. I also thought that in the section we have on being informed by lived experience, this would be another place to try to figure out, can we get information on peers in terms of their rural agricultural sort of background and status to know if we're reaching that area or not. And then because I'm worried about missing the discussion on the next section because I got to leave for my flight, I wanted to jump to the substance use discussions from last month. And a couple of things came to my mind. We have this section on collaboration and coordination between systems. And what I remember hearing a lot of is that we still need better collaboration between mental health and substance use systems. And so figuring out concrete ways to measure that. One would be, are we increasing the use of secure withdrawal and monitoring beds? In particular, are we getting patients from the medical or ED system, since that seemed to be a point of contention last time? And then lastly, I would say, for the creation of new crisis receiving centers or clinics, knowing how well they are able to actually manage people who come in with detox and substance use needs in particular would be important to know.
So to clarify for folks on Zoom too, Dr. Snowden has to leave a few minutes early to catch his flight, but he dove a little bit into our other questions, and I'm really glad he did, because we'll be moving into that shortly. But I appreciate what you said, Dr. Snowden, about, and then this is something Representative Dent has said a lot about cultural competency applying to rural and agricultural communities. I'm also reflecting on what Claudia just said about migrant farm workers and how that's different kind of cultural competency than for the farm owners. So I appreciate you raising that. And also, sorry, if you don't mind, Michael, just skipping back to it. I just want to make sure I'm tracking everything. No, I appreciate that. And I just want to reflect on what you said. I was thinking about, as you were talking about the collaboration between substance use disorder and mental health systems, that isn't really something that we did a deep dive into in February, but it was a big takeaway from our discussion last month. Okay, up next is Bipasha, and safe travels, Dr. Stone, when you have to go.
I just wanted to reiterate what Darcy said. I was looking at a safe place to be, and it's a very short list. So just wanted to reinforce what you said. Coming back to this other document, the crisis response system is financed sustainably and equitably, tracking staff retention, hiring, and turnover. You know, we as the lived experience keep talking about getting input from the people who are using the system about how they're finding. I will say also, because I work on the crisis line, you need input from the staff who are on the front lines of your agencies, please, because it's just human. It's not a good or bad thing, but when you rise up the ladder, you showed your agency in a different way than the person who is actually on the front lines of your agency doing the actual work. So I think something to the effect of asking them how they're experiencing it, because secondary trauma is also a real thing when you're actually doing the work directly. And I, have heard leaders say, oh, I'm trying, but none of my many hundred staff understand. If you as a leader think multiples of your staff are not understanding, you are not a good leader. I'm sorry, I'm just going to say that you can't have 200 stupid people working for you. Then why did you hire them in the first place? So I think this is staff we're talking, but always as lived experience, we're wanting to talk about the people who are most marginalized in systems, and it's been big agencies. It is the people who are way lower down on the rungs of those big agencies. So please consider their input too.
Great point, Bipasha, about expanding our inquiry with lived experience to also people who are working on the front lines and getting their voice in all this. Okay, I think it's time. Well, let me pause. Actually, we do have some chats. I apologize.
There are some chats.
Okay.
And okay, so there's someone that is not a CRIS member, but a rep from the state wants to know if they can share.
Let's start with this.
Okay. All right, so let's see here. Jane Meyer, I haven't read all these. Is this statement in the document, the crisis response system is coordinated and collaborative across systems and community partners, referring to the behavioral health system only or to potential coordination with social service systems? For the panel today, it seems that making those other connections could help to resolve a crisis as well as mental health counseling night. The crisis response system is coordinated and collaborative across systems and community partners.
So what I think I'm hearing Jane say is that a lot of what we talked about was specifically within the crisis system, but what we heard today from the agricultural panel is in rural areas, there isn't necessarily a distinction between those two systems. And so if I'm hearing Jane correctly, she's saying that those connections are actually really important. And that was a lesson we took from the agricultural discussion today.
So Jamie, this is Jane. I think what I'm trying to say is the issues that folks present with can go well beyond a behavioral health crisis, right? I mean, if I'm about to lose my housing, that's probably going to put me into a crisis. And so if you're talking cross system, are we talking about trying to get people linked up with other services? And I think Michael sort of alluded to this as well. And I know we shouldn't expect 988 to be everything to everybody, but just thinking about what the root cause of somebody's coming into crisis might be and how it might be related. It's like Abraham Maslow's hierarchy, right? If it's about meeting basic human needs, then we shouldn't assume that just getting somebody linked up with a therapist is going to solve their problem related to meeting basic human needs.
Thanks for clarifying that, Jane. And yeah, that was definitely something I heard in the presentation today, and the panel discussion was. Please.
Like part of the theme here is about how are we collecting data on referrals, and then can we talk about outcomes? I mean, is there a way to track, especially through the follow-up calls and everything, what the outcome of some of those referrals are? And I would probably be remiss just to say in general, I mentioned the 911-988 partnership. Most of those calls, all of our 3 call centers are also incorporating 211 in connection for especially for those social service type of referrals. So just want to make that note. I think there's still probably gaps in the system, but I want to let everybody know, or potentially other types of local or community or statewide resource lines as where people are getting connected to.
Thanks for adding that note, Michelle.
Then there's a chat from Rep Orwell saying, I want to make sure that the next day appointments data distinguishes between Medicaid and private insurance. So I added that. Puck has a comment that there's some consumer rights stuff here. Puck, not sure if that was specific to someone else's comment.
Just in terms of, I think it might have been Michelle. I don't remember who saying that, like, maybe Devin, we need to make sure we're not applying things onto people. And that just made me think about, like, you know, we get a lot of stigma based on like incorrect diagnosis and things like that traveling through the system. And so if we are keeping individualized shared information, we need to make sure that people have access to knowing what that information is and trying to correct it if it is incorrect.
Puck, I think if I'm remembering correctly, that was when Dylan was talking about substance use disorder and how we were tracking that. Was that when that came up for you?
Yes, Dylan, thank
Okay.
you.
Yeah.
And then speaking of Dylan, I think this is a question for you. Dylan wants to know if the 211 incorporation is a warm handoff or a call transfer.
They're all warm handoffs.
Thank you, Michelle. Any other
Great.
comments?
Last one. Well, there's one from Michael Robertson. Let's be careful that equity isn't a blanket approach / application. Different equitable considerations are missed because the more palatable approach is easier to execute, and in turn drowns out the obvious and more vicious inequities that have always persisted.
Anything else? Okay. All right.
Need to be.
All right. And you're putting Michael's comment in there too. You put
It's up there.
Thank you. I appreciate your scribing. Okay, let's we started diving into it, but let's get your thoughts on the other big questions we asked, which is we've now gotten we've had a panel on substance use disorder and co-occurring mental health and substance use disorder. We've had today's panel on agricultural sector and rural behavioral health. Based on what you've learned, what additional modifications or changes or updates do we need to make to this work we did on meanings and metrics to address those communities and their needs? Kristen.
Yeah, so one of the things that came up immediately for me is under guiding principle 1, people in crisis experience timely access to high quality coordinated care. One of the things that's talked about under those meetings and measurements is that appropriate referrals are made, but I think we also need to track whether appropriate referrals are available for both agricultural communities and for SUD. Is there a facility or a service available in that community? Is there a facility that can take someone for detox and a mental health concern at the same time? Because you can't track whether a correct referral was made if the referral that needs to be made doesn't exist.
An excellent point, Kristen, about a missing metric. Thank you for that. Alicia.
Hello. I'm a little bit going to be repetitive. I see the missing component of 911 services that are provided. So there's an increase in a lot of fire EMS agencies growing various programs that support behavioral health services, such as doing induction in the community immediately when engaging with somebody as a result of a 911 call, and then transitioning that person either to the emergency department or to another program that can assist with ongoing services. So I think if we're talking about capturing all of the services and getting a good picture at what exists, it's also knowing what services exist within the 911 response system to people experiencing behavioral health and substance use crisis, or solely substance use crisis.
Thank you, Alicia. Other folks in the room? I'm wondering if this crowd's tiring out a little bit. We've been at it since 10 this morning, so it's getting on 4. Do you have any chats, Michael?
No. I'm caught up.
You're caught up? Okay. Well, Kristen.
I wrote down so many things, you guys. For guiding principle 4, I think it was in relation to the providers mirroring the demographics of the communities they're serving. One of the things that we could have as a meaning or a measurement is that there's education or training programs in those communities to create providers in those communities that are from those communities. And if those programs do exist in those communities, we need to be measuring how many people that go through those programs actually enter the workforce and then are able to serve those communities that they come from. And then I had another note that for guiding principle number 2, where it talks about safe services, it sounds like for the agricultural communities, one of the things that safe needs to mean for them is confidential in a different way than it means for urban communities. It's not just that our health information is protected, but it might also be that just your neighbor doesn't see you walking up to a building that says anything about behavioral health services on it. A much more like physical and visual form of confidentiality is needed for folks to feel comfortable accessing services.
So it sounds like we need to go into our meetings and maybe define them a little better to also be inclusive of rural and agricultural communities. I just wanted to share with you a conversation I had with Rob Bates, who's one of our panelists today. He was, prior to doing this work as a licensed social worker and providing counseling, he was in the military for 20 years. And so he's, goes to the VA, and he's very involved with veterans. And he had a thought along the lines of what Kristen was talking about, that it would be interesting to recruit veterans and because they do get funding for schooling to actually get degrees in social work and counseling, because so many people in the military come from rural areas. So it was his idea of how to increase the workforce. And I was just thinking, as Kristen was talking about her idea of that kind of training, that fit nicely with what Rob was suggesting. Any comments?
This is actually from Nicola, wants us to mention that we are also working with the Tribal 988 subcommittee to gather tribal considerations, and we'll bring forward those to a future meeting. So just so folks know.
All right, I'm not seeing any other hands. Any other comments? Pasha.
Okay, so this is I don't know how it fits here, but the 988 service, from what I understand, and please correct me if I'm wrong, is a general life a phone line for anyone in any kind of crisis, if especially behavioral health crisis. We've had this discussion in our little lived experience work group, is that you're not going to have people who answer the phones who fit every demographic of human being out there, especially in the United States, given it is such a diversely represented country. And so there's going to be some honest looking into what is 988 going to be. It cannot be everything for everybody. And so we talk about how every person who's trained to answer the call, like I work on a crisis line, it doesn't say what kind of crisis. I just have to answer whoever calls. My first job is to be present as a human being to that person, regardless of their background. And I think that is one of the most fundamental trainings all crisis workers need to have. If I happen to be talking to someone from the African subcontinent, I'm not from there. I'm not going to be able to relate 100% to what they're saying. So at some point, referrals will need to be made, if needed, into those sub communities. So when we look at the whole system, there has to be some kind of interaction between 988 and really even grassroots service providers out there in communities that 988 cannot possibly have. And similarly for the mobile crisis team, you cannot have people who go out who cover every demographic. You're not going to meet people's needs no matter how many crisis teams you put out there. So we need to keep that in mind. And I have to tell you, in the agricultural panel, I think Dan McMorrin said something about, we don't want to, fourth generation farming family, said, we don't want to let our ancestors down. When he said that, I'm like, you just sounded Indian to me, okay? So, and I think what I'm trying to say is we talk about stigma, broadly speaking, but I think there are elements of stigma that cross culture and cross boundaries. And I'm hoping we can have at the CRIS or anywhere, any level, an honest conversation of what is stigma. We throw that word around, but what does it mean? And my gut feeling is there'll be a huge amount of overlap in many cultural definitions of stigma. It will not be specific to that. And then there will be nuances too. But I think, I don't know if there's any expert who knows the world of stigma and what that looks like across multiple communities that can come speak to us. So we can really talk about what does it mean to address stigma in behavioral health, whether it's, DOH, HCA now putting out materials out there in terms of destigmatizing stuff. And I think whether you talk to, we just had 3 kids die by suicide last month in our East Side King County. So these kids are coming from privileged backgrounds. So it's affecting a lot of us. And I really hope we can have an honest conversation of what stigma means, because when I hear other communities talk about stigma, I relate to that, having grown up in India. And I think it'll help bring us together in a way where you'll realize, oh, this person who grew up in India can identify with what I consider stigma in my rural agricultural community, and that they're maybe we're more tied as human beings in the way we look at things than we are separate and siloed. So.
Thank you, Bipasha. You gave me a lot to think about in what you just shared. And I think that would be a really intriguing conversation for us, or maybe the lived experience subcommittee, or to have about stigma and what that means. It's certainly come up as a common theme throughout our 3 years together. So, okay, I see 2 hands. We probably have time for those 2 hands, and then we are going to have to wrap up and move to our public comment period. So it looks like Dylan and then Puck. Dylan?
Hi, Dylan again with Asian Counseling Referral Service. Jamie, what you were sharing, the conversation with one of our panelists about increasing the workforce with folks who are veterans or really all sorts of things. And we're talking about social workers or counselors. But we also have a lot of rich experience with their peers and looking at how we can continue to encourage those to, either become a peer counselor, or taking that for mental health first aid or similar types of training. And so looking at all different types of levels that we can do that. And speaking to what Bipasha was talking about, managing and breaking down stigma, it can really help normalize by increasing the use of peers and increasing awareness by folks within communities to support each other. And also what Representative Dent was talking about in the Midwest of farmers being able to come together and have coffee and be able to talk and support each other.
Thank you, Dylan. Puck.
Okay, cool. Sorry. Thank you, Dylan. Yeah, I think about what Representative Dent was saying and about how, Rep Dent is someone who is willing and able to talk about this because he's been through it. And we know that there are other farming families that have been through it. And at some point in their healing, they're going to be ready and able to support other people. And that's where I really like the Promotoris programs, where you find the people in the community who already care about the thing and you give them the support and education they need to support it. Like, I don't need a peer counselor who has my specific experience, but I need a person who has gone through struggle and who knows how to listen non-judgmentally. Like, I even just in the presentation, I heard them talking about like, don't ask them why they don't just do something else, right? And like, yeah, we have a ton of reasons behind that, but like that's not the road we need to be going down when we're doing this work anyway. Like, I think we really need to pay attention to what support needs people have, and are they engaging with us? And if they're not engaging with us, why not? And I feel like that, I feel like so much of the system failing people is our call responders and stuff accidentally screwing things up. Because when you're in trauma and you're reaching out for help, you don't have as much patience for outsiders being not able to help. And so if you can't have that, oh yeah, I was from a farm family conversation, can you have I obviously don't know what you're going through, but I've been through some stuff myself and I want to help you. Like, I just keep coming back to who's not using the system and why, and like what callers expect versus what they get. I think that I'm excited about these metrics, but we still need to be gathering those ungatherable metrics of the people who aren't engaging, because we can't make a better system only by asking the people who the system is working for.
I hear you, Puck. I appreciate what you just said about that. This is the missing metric of how we get it. Who's not using the system but needs it, and why is that? So thank you for that. I'm just going to check time here. All right. Yes, we're right at time. Nicola, can we just run briefly through the action items? I know one action item is DOH is just going to update that slide, the graph slide, and we'll put that up on the website, the revised version. Are there any other action items that I missed?
That is all I have for now, but we will comb our meeting summary and follow up on any specific action items.
Okay.
For sure. So,
okay.
Yeah.
Great. And then one action item for all of you, just a reminder, if you parked at the Davenport Hotel across the street, please come see Liz for a parking pass so you can get out. We're going to move into our public comment period. Do we have any other signups, Michael? I think I have 3 people signed up today. Okay. 3 people signed up. We're going to do, Chloe's going to put up a timer. So you'll have 2 minutes for your comment. I do want to make sure you all get in, and our ASL interpreters have a hard stop at 4. And I know a lot of people have flights to catch. So that is, I'm going to be not super strict, but fairly strict about keeping time. So please try to stick with your time today. We have in the order that we're going to take it. This is the order they signed up. We have Sierra Lucas going first, followed by Laura Van Tosh, followed by Melody Euchre. Melody is with us in person, and Sierra and Laura, I believe, are participating on Zoom. So you'll see the timer up when I'm going to call your name, and when you're ready to speak, please turn on your camera and we'll start the timer. So let's start with Sierra Lucas. Okay, Sierra, if you are still on the call, can you just pop up your hand? It looks like Sierra may have dropped off. But Sierra, if I missed you and you are on the call, we'll take you. I'm going to call Laura Van Tosh and then we can check back with you again. So Laura, when you are ready, please turn on your video camera and we'll start the timer.
Actually, I'd like to find out if you could share the screen. I asked Michael.
Sure, yeah.
Yeah, so you have to, are you wanting to send me something?
Oh, actually, I could just share it if you share screen. I guess, should I do it that way?
I don't have control over that, Laura, so I think it'd be best if you wanted
Actually, I think I'm here now.
Okay.
Okay,
Oh,
do you see an email?
Yes.
Okay, great. You see the email?
Yes.
Oh, wonderful. I'll just keep it up for a couple of minutes, or my maximum. Today, this is an email with our agenda that we had today. There's a consumer networks, sorry, pardon the language, a peer networks meeting that meets at the King County level monthly. We may be increasing our meeting cadence and meeting more frequently, but what's happened is SAMHSA has issued an inclusion policy, which I will show, I will send it in the chat when I'm finished with this. And it's a nationwide policy on including peer voices in a number of arenas. And Susan McLaughlin, who's the new director of the Behavioral Health Recovery Division, created this agenda that you're looking at, which was today's meeting. And number 5 are list 5 areas that we focused on. The first area today, where we can begin to insert the engagement and direct action of peer involvement in county government related to the Behavioral Health Recovery Division. And so we're creating a platform for peers to ongoingly affect change in partnership with the Behavioral Health Recovery Division. In other words, we're identifying meaningful ways for peers to be involved in planning, delivery, administration, evaluation, and policy development. And this cuts across the Crisis Care Center levy, as well as other, obviously, other programs that the Behavioral Health Recovery Division is responsible for. And this is an answer to the question of engaging peers more deliberately and systematically in partnership with the Behavioral Health Recovery Division. We're very happy that Susan McLaughlin has taken the lead on this, and she led our meeting today. We've had varying levels of engagement. I've let Bipasha know, I think they're on the list to get notices for this meeting. And this is an example of how we can directly engage peers in policy and all the other areas that I mentioned. So I just wanted to bring that up as an example of how peers are going to be getting more involved with the Recovery Division. So what I'll do is put the SAMHSA Office of Recovery policy statement in the chat, and that concludes my comment. Thank you.
Thank you, Laura. Up next we have Melody Euchre, who's in the room with us. And then I'll check back to see if Sierra Lucas is able to join us. So Melody, when you're ready.
You better use that timer for me.
There we go.
Melody Euchre, she, her pronouns. I've been attending majority of these meetings, probably 80% of them. I'm more like Betsy. I'm quiet in the background. Turn my camera on every once in a while. And you know, this comment I'm going to talk about right now is something I brought up at the beginning. And it's something that's near and dear to my heart, because At Martin Hall, we cover 9 counties and 2 tribes. So if you want, experience with working with rural kids, I've got it. But I also chair for Prevent Suicide Spokane Coalition. And so I have a great email list for any kind of lived experience or other kind of experience that you might need as far as helping you guys out with committees. I got you covered for Spokane area anyway. So, but what I want to talk about is that's a huge gap is treatment for youths that are 12 and under. And I haven't been on a transport in a couple of years. And I was asked last Thursday if I would go pick up this gal, and when I got there, it just broke my heart. She was 10 years old. And I'm just like, are you kidding me? I mean, like, this is the one thing, and I'm already running out of time, but that they come to us because the mental health folks don't have the beds for 12 and under. We do. Our doors are always open, unfortunately, for that age group. And it's something I would love to have a larger, bigger conversation with anybody who would like to have that. And I'm out of time.
Thank you, Melody. I'm going to check in. Sierra Lucas, are you with us still? You, Sierra Michael? See them?
In the participant list.
Okay. I think maybe Sierra might have dropped off. So we'll reach out to Sierra and ask them to send their comment written if they'd like.
You want me to call you?
That brings us to the conclusion of our second hybrid CRIS meeting and our 22nd meeting overall. I want to thank our CRIS committee members who participated by Zoom today and express my appreciation for your patience. I know hybrid meetings can be challenging to participate in when you're on Zoom, so thank you for that. I want to give a big thanks to our CRIS members who are here in the room for some of you making a long trip to be here. I know it is meaningful to travel to across the state to be with each other, and I appreciate you coming today. And as ever, I want to thank I also want to thank our staff for being here and all the work you did to help prepare for this. And as ever, I want to thank our community members, in particular people with lived experience who give so much of your time and your emotional labor to this work. We are grateful for you. I want to wish you all safe travels, those of you who are physically returning home, and everybody have a good evening, and we'll see you. We have a steering committee in May, and then our next CRIS committee meeting, I believe, is in June. So we'll see you either at the steering committee or at our June meeting. Take care, everyone. Have a good night.